Welcome to Between Two Ovaries, your go-to for all things women's health.
A lot of people just say like, oh, my vagina.
Yeah.
And
Yes.
that's
all
not,
of the above.
That's not your vagina.
No.
Well, it is.
We're here to cut through the confusion, bust some myths, and give you the facts straight from the experts.
You cannot still believe the amount of people that come to a gynecology clinic saying that they don't look right down there and they need something doing about it.
We're keeping it real, bringing you honest conversations about topics that matter to you.
Everything goes back to the menstrual cycle. Yes, it's a low-risk procedure, but it's not a no-risk procedure.
From periods to menopause and everything in between, we've got you covered.
So whether you're here to learn, laugh, or just listen, you are in the right place.
As soon as I said it,
Hello everyone, so today we're joined by Dr Saz, who's a consultant in Genitourinary Medicine and HIV Medicine at the Royal Liverpool and Broadgreen University Hospitals. Sarah works at the Axess clinic and covers some fascinating and incredibly important areas, such as diagnosis and management of STIs, HIV, contraception, outreach work, adolescence and LGBTQ+ health. Dr Saz is also a trainer for healthcare staff and works at the Liverpool University School of Medicine. We're really excited to have you on the podcast, Dr Saz, and we want to hear you talk about your work, your journey, and also what is next in sexual healthcare.
So thank you for coming.
Thank you.
So we usually just kind of say why it's important that we're doing this episode. So there's still so much stigma and misunderstanding surrounding HIV. And even though the science and treatments have come such a long way, the episode is about changing that because we know that knowledge is power. The more we understand about testing, prevention and treatment, the more empowered we all are to take control of our health. We need people to understand that HIV does not just affect men who have sex with men. And I think that is one of the main issues that people are like, well, it's not a me problem, it's a them problem or a other people problem and it won't be in my life. So we'll be breaking down some common myths as usual, talking about how HIV testing works today, including new developments like opt-out testing, and exploring how treatment means people can live full, healthy lives and not pass on the virus to others. Most importantly, this is just about empowerment. Whether you've never tested before, you work in healthcare, or you just want to be a better ally, this conversation is for you. So thanks for coming.
Well, thank you for having me on your excellently named podcast.
Thank you.
We put a lot of work into this play.
Yeah.
So can we start? Because I don't know about Eleanor, but I certainly don't know a lot about, I don't even know how you said it, genitourinary medicine?
Yeah.
What is that as your role, and what does like a typical week look like for you?
So, it's GUM, genitourinary
Okay, I've heard
medicine.
that.
I feel like that
Makes way more sense.
We can say that from now on.
Yeah.
It's a
makes it much
specialty.
easier.
It's a specialty people haven't heard much about. So it's helping diagnose and investigate people with symptoms around their genitals. So whether that's a skin problem, a discharge, bleeding, pelvic pain, or a testicle problem, if you're a cis male. And it's also about treating and diagnosing STIs, but also about preventing them, providing contraception and support around healthy and consensual relationships, and helping people that might have been through something distressing like assault. So it's a really diverse specialty. So I do GUM outpatient clinics, so people can walk in with problems on certain days of the week, and we do booked appointments. I'm also a doctor in HIV medicine, so I see people and monitor them and provide treatment for people living with HIV, and I see them twice a year if they're stable. I work with some community nurses, so we provide care to people that never set foot inside the hospital. So there's a lot of work going on beyond the sort of walls of where we work. I train nurses to get more advanced qualifications, so we have advanced clinical practitioners. I teach at the medical school, which is very entertaining. So I've just got to give a shout out to the Sexual Health and Guidance Society, the SHAG Society, for all the great work they're doing with the student
Honestly,
body.
like we were having a discussion before we started filming. Like, I'm not being funny, but GUM, so GUM, as we've said, have all of the best names. So they have
Great
the
acronyms.
SHAG Society at the university, great one. And then we were just talking about the other conferences going, you're going to have to fill people in because these are great as well.
British Association of Sexual Health and HIV is called BASH.
Which it sounds so official, doesn't it?
Yeah.
You're like, this is a great one.
It demands attention.
And then you're like,
Bash.
And then there is BEVA, which is the British HIV
Honestly.
Association.
That is my favourite.
then there's STASH, which is the Student Association for Sexual Health. So.
I just feel like you won't be able to get away with anything like that unless it was in GUM. I think that they're just like, we got this.
Yeah, we've got you covered.
We're going to own
Obs
these
and Gynae
names.
have SNOGs.
The SNOGs as
which
well,
is the Student Neonatal Obs and Gynae Society. And I don't think they really cover anything neonatal, but whoever created it was just like, we need it to be SNOGs, not SOGs. But it works well.
Better than SOGs.
So much. Yeah.
So what first drew you to the field, and what made you go more into like the HIV side as well?
So, although it sounds corny, I make a real difference to people's lives day by day. And it's really interesting. You never know what's going to walk through the door. And sometimes it's very dynamic. So there's a lot of change. So every 6 months, what we change, what we do in clinic. So there's new vaccines that have come out this year. There's new treatments that have come out this year. You don't just learn it once. It's a really dynamic specialty. So, for example, before COVID, if you offered someone a home test kit for sexual health, people really didn't like that idea. But since COVID, people have really adopted that. And now we do thousands of home test kits in Liverpool, where people in the privacy, in the confidential sort of surroundings of their own home, can do a test for HIV, syphilis, chlamydia and gonorrhea. So things have really, really changed. A gonorrhea vaccine came out in August of last year. So that's now something that can be given to gay and bisexual men that could be at risk of gonorrhea. So things are always changing. The other thing is having the right skills. So you've got to have good chat, a good communicator, because people are sharing really intimate things and sometimes really distressing things. It's a real teamwork specialty. So if you work well in a team, and my team are legendary, that also plays a good part for you. And I have really strong relationships with the patients. So you might meet a young person, they've never had an STI screen before, they've come in with chlamydia, you treat them, you sort their partner out, get them tested, you give them some condoms, you talk about contraception, you check that they're safe in their relationship, because a lot of people don't realise that consent isn't just the absence of a no. You've got to say, yes, I agree to that. So sort of empowering people to have healthy relationships, and then that person is sorted, and then I might never see them again. And then I've got some patients living with HIV that I've known them for years. You know, I know what their dog's called. I've met their auntie. And so you have a very different relationship with those patients. Also, the staff, you know, have a real can-do attitude. I'm going to say this because I work in GUM, but it tends to attract, you know, really cool people that really want to make a change. So it's quite, people tend to be quite passionate about the specialty. There's no one that's just sort of ended up doing it, really. And I think the other thing is our community partnerships, so working with patient support groups. So there's a patient support group that I go to, that I went to talk with the patients. They had some questions about new treatment and why doctors asked you to do certain things. And they sat me next to this really quiet-looking person. And I now think they sat me there on person because this person heckled me throughout my talk. Like really great questions, challenging what I was saying, you know, why do you ask? And it was a real eye-opener for me. And also we work with peer support workers. So many of our peer support workers are living with HIV themselves. So when someone is newly diagnosed, they have that chance to meet somebody else that's got the same lived experience, has been where they are being, and, you know, are coming out the other side and saying, you know, this is where we can get to. And also, it's a really good specialty if you like to dance and glitter. So we have lots of parades, so the Pride Parade. Just check which glitter rubs off before you have to go back to work.
I mean, you can tell how passionate you are about your job. I think it comes through in the way you talk about it. And it is clearly such an important area of medicine, because like you say, you know, you might see someone just once, and even if you just see them once and it's something like just chlamydia, to that person it could be devastating. And like you say, you need to really, well, you will have such a big impact on how they cope with that. But then equally you could be seeing someone for their entire life, which I think is always a really like an honourable thing that you can do within your specialty, to see someone for a long time and, you know, be a real part of their lives. So
because it's not in a bad way that you're seeing them for the rest of their lives, because you're seeing them to just check in and make sure they're okay. And I don't think there's many specialities that actually will have that anymore, because like we see people at various points in their life for maybe a prolonged length of time to try and see if we can make a difference. But you're kind of seeing them just kind of ticking over, are we okay? Is there anything that needs changing up? Is there anything new that's come out that we could think about? And I love that. Like that's a really nice kind of like, hi, how are you? Like a really nice nice relationship, I think.
I mean, you try to make every contact count,
Yeah.
whether you see that person ever again. But with some of my patients living with HIV, you know, I've seen them at diagnosis. I've seen them when they've been really poorly. Perhaps we met in intensive care. And then I see them when they're better. I see them when they start a new relationship. I might see them through starting a family. I might see them through getting a new job or finishing their studies. And it's a real privilege to be part of their journey.
And you're in people's lives when they are feeling super vulnerable, and you're asking questions that most people would be like, I can't believe that you're going to ask that. What do you mean? Like, how many people have you slept with this week? Ever? Forever? And is that, what kind of sex is that? Is that female to female, male to female? You're asking all of these questions. And I think a lot of the public wouldn't get that these are kind of normal questions for you, and you're not shocked, and that's why people can come and feel comfortable. And I do think it's a setting where when you go in, you're like, oh, this is just routine. It's just kind of like having my blood pressure checked. They just need to know so that they can make sure that everything's kind of correct and that we're doing the right tests for you. But it is when people are feeling vulnerable.
Yeah, I mean, your entire job, I suppose, is a big factor of it is breaking the stigma associated with the diseases that you cover, and that's very much what we want to do in this podcast as well. So I think it's a nice
Crossover.
marrying, yes.
I think it's really important to tell people that when they come to a gum clinic, it's confidential. So if I'm seeing an adult, everything we talk about is confidential unless they tell me something about someone else being at risk, and we talk about it. We have a safeguarding team. We ask everybody about their safety and relationship. I mean, in younger people, in the eyes of the law, we have to ask additional questions to check whether there's any other areas of support needed. But the tests are done under a number. They're free. It doesn't link up to your GP records, so it is really a safe space, and we tell people what we're going to ask about, you know, your lifestyle, who you're having sex with, whether you feel safe, whether you smoke or drink alcohol, and all these things are relevant to sexual health. And it's also about giving people information so they have those choices. They're empowered to think about ways that they can protect or care for their own well-being.
So we are obviously a women's health podcast, and people might be wondering, why are we covering HIV as a women's health podcast? Would you like to enlighten them?
Oh, yes, yes. We don't talk about or to women enough. Women are really underserved in so many areas of life.
Well, we hear you.
Exactly. Okay, we're half the population. We deserve half the space. And I think unfortunately it's throughout. So there are lower rates of sort of testing. So for example, everyone that comes to a sexual health clinic, we offer an HIV test too, and the uptake we aim for is sort of 95% and above. And in women in 2024 it was only 64%.
Wow.
And that's lower than other groups. And is that healthcare workers thinking, oh, this person's just coming in for a change of their coil, they've been married forever, only have one partner, I don't need to offer this test? Or is that the women thinking, I'm not at risk, you know, I've been in a long-term relationship, I don't think this is me? So we've got to do better with testing. And you know, increasing numbers of HIV is being diagnosed in women. So over the last 6 years, there's been an increase of new diagnosis in heterosexual women of 33%, whereas in men that's dropped.
Right.
And the other issue is getting diagnosed with HIV late when there's damage to your immune system. And women diagnosed with a later stage of HIV is increasing as well, whereas it's decreasing in other groups. So testing is really, really important. When we're thinking about prevention methods, women are also underserved. So out of all the people that take something called PrEP that we'll talk about later, which is an HIV prevention medication, at the last survey in the UK, only 1% of PrEP users in the UK were cisgender women, so assigned female at birth. And they've done a bit of work to think how many people might need it, and they think there's about 130,000 women, heterosexual women, that could benefit from PrEP. So that's why I've elbowed my way into your podcast.
Yeah.
Why do you think that people don't assume that HIV in a sense affects women? Do you think it's because of kind of looking back and looking at like Freddie Mercury and looking at like the work that Elton John did and the work, do you think it's because people still live in that era where actually it doesn't affect women, it affects men? And because I think we've got that message across, that message is there. Do you think is that why we're missing the whole female message?
So certainly the history, there were horrible phrases like the gay plague, and HIV wasn't diagnosed till 1983. We didn't identify the virus, and it devastated communities, sort of in San Francisco, men who had sex with men, people that had contaminated blood products before screening came in. So it devastated certain communities, and these were communities that were not popular politically. So, it wasn't a great vote changer to say, I'm going to invest loads of money in testing this new virus and for treating this virus. And, it took from 83 to 1996 to get effective treatment that worked.
Wow, that's a long time.
That is a long time, and so many people died. And people began to associate it with just those types of people, just those groups of people. But actually, worldwide, I think there's 40.8 million people living with HIV, and over half of those are women. So
I think
it
a lot
is
of it
relevant.
must be as well, like how the media, it just shows how the media controls the general population's perception of something. Because, unfortunately, the media will have said very negative things about men who have sex with men and people with HIV, and then that has stuck in people's minds and just shows how much damage it can do to a population.
Before we go any further, would you be able to just give a little description of what HIV is for our listeners?
So HIV is a virus that can be passed by contaminated blood products, so normally semen or blood, and it can affect your immune system. So we have these cells that protect us against infection called CD4 cells, and if you get infected with HIV and you don't know that you've got HIV and you're not on treatment, the virus starts to damage your immune system. It's very good at getting into cells and making lots of copies of itself, and then your amount of virus in your blood rises. Now the CD4 cells get affected by the virus if you're not on treatment and get lower, and then you're more likely to get infections that wouldn't infect somebody else. So you're more likely to get fungal chest infections, you're more likely to get infections in your brain, in your gut, you're more likely to get problems with your sight. It can increase your chance of frailty, of kidney problems, bone problems, heart problems. And if people are living with HIV for a long time off treatment, then they won't live as long and they're more likely to get sick and be hospitalised. If you diagnose someone with HIV early, before that damage starts, you get them onto treatment, then they can live as long as somebody without HIV. And I think that's a really, really important thing to say. Treatment is really important. So the sooner you begin your journey, the better your outcome will be.
So that's why we talked about testing, and we'll move on to that. But with regards to women or men, sometimes when you're working in a hospital and somebody's got some weird chest infection, for example, then you would be trying to think out of the box, and that's when things like HIV would come up, because people don't routinely have weird chest infections or weird gut infections or a brain infection if they've not got something else that's affecting their immune system. So it wouldn't be a normal thing for people to have. So it's kind of one of the sidetracks. Have you thought of HIV in that situation?
It's also incredible when you think about if the infection itself wasn't really identified till, was it 1998 you said?
1983.
1983. And then now in 2026, and you can have a test and treatment that means that your life expectancy is exactly the same as if you hadn't got the infection. It's incredible. And it's a shame that there's people's general perception, thank you, of it hasn't also caught on, because that's an incredible thing to be able to do.
The perception has not caught up though. However much we sit here saying knowledge is power and people should know and people should get tested, even in 2026 there is still stigma behind that, and you can see it. You see it from a healthcare setting, you see it from a day-to-day setting, and that's because people just don't understand. They think that they can get HIV by shaking somebody's hand or having a kiss or having there's so many different things that you're like, how do we just not get this? That's a whole other rant though, isn't it? So
one other thing, I'll join you in a rant, is I think that women have always been underrepresented in clinical trials. So a lot of the early trials for HIV treatment and HIV prevention were in men who have sex with men. And I think people get nervous about putting women in trials where they might be thinking about they might be pregnant, they might be chest or breastfeeding. So we won't include them because we don't know if this drug could affect them. But in the real world, there are people that want to get pregnant, are pregnant, or chest and breastfeeding. So when you want to then use that drug in the real world, there's a whole group of people we don't know if it's safe for. So, and over 10 years, recruitment of women to trials hasn't really changed that much. So we can do better.
Yes.
Agree. So let's start with testing. How often should people be tested for HIV, and who should be considered for kind of regular testing?
Okay, so I think everybody should have an HIV test. Everybody should know their status. So I always start a conversation with people as, are you tested or untested?
Okay.
And, it's amazing to me when I meet people that might be on their 40s and 50s and have never had an HIV test. So in America, they sort of recommend, everybody in their adult life should have a test. So if you're thinking about, is it relevant to me? So have you had a new partner? Have you had sex without a condom? These would be reasons to think about having a test. Do you have symptoms? Are you going to go and get some contraception at the same time, get a full checkup?
Yeah.
Are you planning a pregnancy? Have you been contacted by a partner saying they've had gonorrhea? So I think there's lots of reasons to have a test, and especially if you've never tested before. Testing is something that everybody should do. The other thing to think about is if there's any barriers to testing and how you test. So thinking about if you find it very difficult to come into a sexual health clinic, or you're worried that your boyfriend or your mum might know where you are, then there are lots of different ways in which you can test.
Okay.
Go on, tell us more.
You can get a home test kit.
Okay.
So just talking about Liverpool, but you can do this wherever you live if you Google home STI tests. So you go to our website, so it's www.axess, it's AXESS, see what we did there, .com. You go to services and order a test kit. And it will be sent to your house. It's in a little grey packet. It doesn't say this is a sexual health screening all over it. It just looks like an innocuous, online package. And in there, there's a swab that you take from your own vagina to look for chlamydia and gonorrhea. And there's a finger prick blood test that you take for HIV and for syphilis. So drink loads of water, have nice warm hands, and put your fingers down when you're doing your blood tests so you're not working against gravity. And then after you send it back, from the date you send it back, you normally get your results within 5 days by text or email.
Amazing.
So this is free, it's confidential, and you can do it in the sort of peace and quiet of your own home. And people feel quite comfortable with
And
that.
it's easy.
It's
Yeah,
easy,
very easy.
it's quick.
Can anybody get one?
Yes,
You just fill in
so
your
wherever
application
you live
form.
in the UK, most people will have access to it. But if you live within the Liverpool area, then that's the way that you do it. There's SH24. You can pay for private tests, but you don't need to. You can
Right.
test for free, everybody else.
Yeah.
I mean, I was doing an online grocery shop last year, and I think I was trying to get like some home COVID tests. No, it must have been a few years back. And actually, when I tested home tests, there were home test kits for pregnancy, there were home test kits for HIV. So like you can even do it on your grocery shop.
Yeah, but you can get them for free. You don't have to pay.
Exactly. Come to Gum Clinic. We
Yeah.
offer them to everybody. It's confidential. It's free. You'll get your results. You can do it at your GP surgery. You can ask them for a test. You can do it in hospitals. So if you're admitted, we might think an HIV test is useful. Or if you're in an outpatient clinic, again, people will be offered HIV tests. And in some areas, A&E, which I think we're going to talk about in a bit.
Can I just ask, because people might be wondering, so if you go into your GP, you'll have I'm assuming, you'll have a blood test, as in you'll have needle in your
Yes.
arm, blood drawn, whereas if you do the home testing kit, it's a little finger
prick.
prick that you can put on a card, is it, or something like that maybe? Or
It
put it
goes
into a
into a
bottle?
little tube and then you send it back.
Are they both as effective? Is the finger prick
Good
test
question, Alice.
potentially less
Right.
effective? You know.
So they are both really useful tests. So a blood test from your arm is the most accurate type of test, and it can take 45 days for HIV to show in your blood. So if you come into Gum Clinic, you've maybe had sex with somebody new without a condom, but it's only been 2 weeks ago, we can do a test for you then, but it's a good idea to repeat it 45 days after that potential exposure.
Right.
If you do a finger prick test, it is better at looking at infection that you've had for a long time. It's not
Right.
good at picking up early infection. So if your test is non-reactive on a finger prick, that means up until 3 months ago, there's no evidence that you are living with HIV.
Right, okay.
Occasionally we get false reactive tests. So anyone that gets a reactive result on a home test kit comes into clinic, we repeat the tests, both finger prick and from the arm, and we could do an extra test to look for HIV virus in your blood as well.
Right,
So it's rare,
So you
but it
can
does
have
happen.
a false positive.
You can have a false reactive test on a finger prick test.
Right.
The tests we do from the arm, it's confirmed with 2 different tests, and we follow that up with a test to look for virus in the blood, and that's the first thing that appears before people develop a protein called an antigen and an antibody.
Right.
Okay.
So yeah, the most accurate ones are the ones you get in clinic.
Yeah, but then it's so easy to just go online, get your home test kit and do that. If that's a barrier for you, if you don't want to go into your GP, then you can just do it at home, and that is a very accurate way of
And
testing.
sometimes people, if they get a reactive test, will then keep testing a number of times before they access healthcare.
Right.
A bit of work I did several years ago. So, you know, if you have a reactive test, come in and see us.
Yeah.
Don't sit at home and worry.
Yeah, come and see us.
Share the burden.
Come and get
Because we'll do all the tests for free for you. We'll give you all the right counselling and support, and then there'll be pathways you go down depending on what we find. And just to say, if you've ever had syphilis before, when you do a finger prick test, it will always be reactive because you carry a protein in your blood. So if you've had syphilis before and you want a test to find out if you've got it again, a blood test from your arm in clinic is the best way.
Yeah.
Oh, that's
That is good knowledge.
Yes, that is good knowledge. I'm sure that brings up a lot of drama sometimes.
And when you're ordering a at-home test,
Yeah.
is there any like dodgy ones online? Is there anything you need to look out for to make sure you get a good quality one?
Great question. There are some very unscrupulous private companies that will
You used a nicer word. Eleanor's like,
Dodgy.
dodgy. Any dodgy ones?
Well, I just feel really bad for patients when they've paid hundreds of pounds to get a test kit which tests them for lots of things that aren't recommended nationally that we test you for. They're told you've got this random bacteria, but we don't treat you, and then they come into clinic.
It's the same with everything, because it's the same with at-home AMH testing. It's the same with people were saying that you could have a blood test to see if you were having a boy or a girl when you were like 4 weeks pregnant after a finger prick test, and people were spending
You're
£500.
just inflicting pain on your finger.
And if it was wrong, you could have your money back. Well, clearly it's just an absolute scam.
It's a good business model, isn't it?
People are just making money out of patients' fears, like exploitation. So I really encourage people to come in because you'll get the knowledge you need, your questions answered, you'll get the correct tests that are right for you. There are some tests we don't recommend unless you've got certain symptoms in sexual health, but if people test at home, they might pick up something that doesn't need treatment.
Yeah.
So I think it's really important that you have that information to make the right choices for you.
Yeah.
But yeah, you're right. Just avoid, I can't
The
list
dodgy
them,
ones.
but
Unscrupulous? Is that
SH24.
what you said? Unscrupulous. New word
Taking
to my
advantage of
dictionary.
people.
You were going to say what SH24 is. I was going to ask you before because we've not.
Yeah,
it
so
might not be
they're the
general.
provider we use in Liverpool for home test kits.
Okay, fine.
And what is a fast track city when it comes to HIV?
Okay, brilliant. So the Fast Track City is an initiative. It's all over the world, international, so it's over 200 cities that recognise that they have a lot of people living with HIV in their city, and it's about getting better care, getting people diagnosed, getting them on treatment and reducing stigma. So we've got some shared goals. So Liverpool is a fast track city, so that's why I was really keen to come and talk with you. And we want to get to 0 new HIV infections by 2030.
Okay.
We want 0 HIV related deaths. And we want, perhaps most difficult of all, is 0 HIV related stigma. So being part of a fast track city means we are a city that has more HIV than other cities. So we say more than 2 per 1,000 is what we call a high prevalence city. And some of the last data suggested we had 2.37 people per 1,000 living with HIV in Liverpool. And it also means that there's some recommendations that go along with that. So it's recommended, if you live in a high prevalence area, that if you register with a GP, you are offered an HIV test. And we know that doesn't happen.
No, it doesn't.
Primary
I just
care have
changed
so
GPs.
much pressure, and we know there are some primary care centres that do hundreds of tests, and there are some that do very little. So we know that doesn't happen. But it also recommends we do something called opt-out testing in A&E in high prevalence areas.
Right.
So have you guys heard about that?
No.
My guess would mean that
I've been
it's you have to opt out if you don't want it.
Exactly.
Okay.
Does what it says
so
on the tin.
everybody who walks through the door at A&E gets a HIV test.
So anybody that goes to the Royal or Aintree A&E who has a blood test
Right, okay.
will then be screened for bloodborne viruses, so hepatitis B and C and HIV, unless they opt out.
And are they told that that's what's going to happen? Or
So there's sort of big posters.
posters.
There's lots of information about it around the department. If they
Yeah.
ask, they will be told.
Right.
So lots of work has been done on opt-out testing, and I did some work when I worked in the south of England, and the biggest barrier to opt-out testing was clinicians being afraid to order it. And actually, if you ask patients, over 90% of them said, yeah, do the test.
If you're already doing it anyway.
You're having a blood test anyway.
there's
Yeah. And what it does is it picks up those undiagnosed infections. HIV is a treatable condition. Hepatitis is a treatable condition. And in the first 6 months, I think they did 44,000 tests between December 2024 and May 25. And they picked up 7 new diagnoses. When they looked at those 7 people, 6 of them will never have tested.
Wow.
Never been to a gum clinic, hadn't been to the GP with any related symptoms.
So saved their lives,
Yeah.
Yeah,
basically.
well, it's definitely changed the course, and getting them in treatment. And it also picks up people that might have fallen out of care. So might have moved around, might have come from overseas, might have had a difficult time. And so it got 2 people back into care as well. So there's that advantage for opt-out testing as well. So, it's another step towards reaching all those people that have HIV
I
but
think
don't know.
it definitely is more beneficial than opt-in, because people are more likely to just go along with it if it's already happening.
Oh, yeah.
Than to be like, let's do this.
And it normalises it because
normalises
it's
it, yeah.
everybody. You're not being picked to have this test. Everybody is having this test.
Well, it's like if you walk into the women's hospital, I promise you'll get a pregnancy test. Like, you have to
Yeah, you
very
hope so.
much
No one's
be...
calling you fat. No one thinks you look pregnant.
We're just we just need to know.
Pregnancy tests and HIV tests for everybody.
Yeah, pretty much.
And just while we're on the topic,
Yes.
syphilis as well.
Okay.
Massively underdiagnosed, and we see syphilis rates are really high in Liverpool. They've doubled over the last couple of years. So if you're having a sexual health checkup, if you're having an HIV test, we test you for syphilis as well.
Right. And that is usually a blood test, isn't it?
Yeah, that's a blood test.
Yeah.
Unless you've got a little ulcer, and then we can swab it to see if that's where the bacteria have entered your body.
And who is syphilis affecting?
Everybody.
Everybody.
I just wanted you to say that.
I thought you were just going for who's syphilis. I thought you were like, okay, who is she?
It doesn't discriminate. It's everyone's getting
Pretty
it.
name.
This is just what I wanted you to
Yeah.
say out loud, because I think, again, that syphilis is not for women. Like, I think that's what a lot of people will
Yeah.
think. And it's just annoying that you just like,
Yeah.
no, we, like,
It
everybody
affects
can get
everybody.
it.
Yeah.
So,
And all ages as well, not
Yeah.
just a specific age.
So-
So you mentioned pregnancy, and we wanted to talk about that. So that's one time where you would be, offered a HIV test in pregnancy. So what does HIV care look like in pregnancy?
Okay. So can I start with just talking about the screening?
Yeah, start at the beginning.
So when you book in pregnancy, I think that's anything between 10 to 14 weeks. So you're offered blood tests to screen for a number of things. So you actually get screened for HIV, you get screened for syphilis, and you get screened for hepatitis. And that was introduced in 1999. And the uptake is really good. So over 99% of women accepted it when I last looked at the data, which I think was in 2022.
because I think it's normalised.
It's normalised,
Like,
If everyone gets it.
I didn't realise it was that late that it was introduced. So that means when my mum was pregnant with me, that wasn't a routine thing.
Yeah.
Whereas now you just don't even question it. It's just
no, everybody
of course
has
you
it.
do that.
It's routine care. It's routine care. And I think one important point just to make about that is that if you test negative at the beginning of your pregnancy for these things, it's worthwhile thinking as healthcare professionals and as patients yourselves, is there any chance I could have got this during the pregnancy? Do I need to have another test? Because we do sometimes pick up syphilis and HIV later in pregnancy where they were negative at the beginning and they've got it during the pregnancy. And also people that don't engage with prenatal care. So I will come and test somebody who's in labour, who's never engaged with care, to do a test right then and there to see if they might be living with HIV. Because even at the moment of delivery, there's things you can do to reduce the risk.
Yeah.
So if somebody tests positive during pregnancy, then the first thing we do is we all work together. So the midwives work with the obstetricians, they work with the pharmacists, they work with the nurses, work with psychologists, and they work with us, the HIV doctors, and we work with older hay and what we call the baby doctors, so the neonatal doctors. So we all work together. Would you like me to talk a little bit about what happens for women living with
I think
HIV?
it'd be good to, because obviously you'll have women that are newly diagnosed with HIV, but then you'll have women that already knew they had it and get pregnant. So there's like a very different. So I wonder if you want to talk about the newly diagnosed.
Sure. So if you're newly diagnosed, you will meet us all very quickly, and there will be a lot of people involved in your care, and that's everybody looking out and working together to keep you safe. We get women on treatment as soon as possible, and this is treatment that's been used for a very long time in pregnancy, so we know that the treatment is safe. We have a register of drugs that we've been using, and we collect data. So much of these drugs have been used for sort of years, even decades. So we put you on a safe combination of drugs. And what HIV treatment does is it brings down the amount of HIV virus in your blood to a level that we call undetectable, so less than 200 copies in a drop of your blood. And we actually in Liverpool get it down to, we measure to less than 50. So we get women established on treatment, and we want them to be suppressed, so their viral load to be undetectable for as soon as possible, for as long, for the rest of their pregnancy and for the rest of their lives. So that's the first thing women take treatment. So they'll have more blood tests to monitor, to check that that's happening. When baby comes to be born, if a woman has been on treatment for 10 weeks, they're suppressed, the baby doctors are happy and mum wants a vaginal delivery, then that is perfectly safe to have a vaginal delivery. If baby comes early, or the virus is higher, or the obstetrician thinks it's safer, or mum chooses, then a C-section for baby to come into the world.
That's a really important point, because a lot of people will assume that a C-section is the only way.
Historically, that's what was done. But if you're suppressed and you want it and it's safe and everyone's in agreement, that's fine. Baby will have some medication after baby's born, and depending on what's happened to mum throughout the pregnancy and the blood test, that might be 2 weeks, that might be 4 weeks, it might be 1 syrup, it might be 4 syrups. And if babies are born early, that's medicine we can give by a drip if they're too young to take anything. So that's the other thing that happens. There'll be more blood tests. So babies get a blood test within 48 hours of being born, at 6 weeks, 12 weeks, and then at 2 years. And then the other thing we talk to women about is how you feed baby. So in the UK, we recommend women living with HIV to formula feed baby. And that's because if baby's born without HIV, there is 0 risk after birth if you formula feed. Now, in other parts of the world, it's safer to chest or breastfeed because you might not have access to formula, water might not be a clean, safe supply, you might not have the money. So in some areas of the world, the advice is different. Now, if women are well controlled on their HIV treatment and they want to breast or chest feed, then we support them to do that for 6 months. We do blood tests for mum and baby, and we make sure there's never any mastitis or baby having tummy upset, and that you don't mix the type of feeding. Because there is a small risk. So if you breastfeed for 6 months, the risk is 0.3%, and if you breastfeed for a year, it's 0.6%. And this is data from a big trial that was done in Botswana in India.
Is that, just to ask, the 0.3, the 0.6%, is that if the mum is undetectable viral load?
Yeah, these were women that were on treatment and undetectable in parts of the world where breast and chest feeding it was recommended.
Okay, so it is still a risk. So that's
it's
why
still
in
a
the
risk.
UK
It's very small, but it's still potentially there. So we say to mum, if you want 0 risk, let's talk about formula feeding. And we try to provide free formula in the UK by charities, local councils. We offer medication to dry up milk supply. And we talk about the other ways you can bond with your baby, so skin-to-skin contact. So if there's another parent, that they're not left out, and that, the important thing is baby gets fed.
Yeah, of course.
So we talk a lot about it because it's a really, emotional and difficult topic.
And it's also nice that, as you said, you're not telling someone that they can't breast or chest feed. You're giving them the advice, this is the risk, and if you want to do that, then you don't just shut the door, you continue to care for them and monitor. So that's
and that you
good.
work together. That is, it's patient-centred choice, but they have the information they need. And our Beaver Association has lots of resources just on this topic. So there's lots of conversations we have when people are living with HIV.
Cool.
Can I ask, is there like a difference in the chance of the baby getting HIV if you catch them earlier or later with those testings?
So when you first get HIV, what happens is in 72 hours, the sort of HIV can get into the lymph nodes and into the blood cells, and it makes copies of itself. And then so the amount of virus you've got in your body goes up really quickly. So, we talked about people being undetectable, having less than 200 copies in a drop of their blood. When someone first gets HIV and becomes infected, they can do something called seroconvert. And the HIV virus is so good at making copies of itself, you can have more than 10 million copies of the virus in one drop of your blood. So you're more likely to then pass it on if you've got a really high viral load and you don't know you've got HIV and you're at that stage of the infection.
But if you're on medication, the chances of vertical transmission is what they call it, which we've had a little chat about this because I was like, do people know what vertical transmission is?
It's mother to baby.
Yeah. But you, Saz was saying that that's not the terminology that people want to hear anymore.
So we're trying to move away from
'Cause it's
things
like
like
stigma.
mother to baby because it's quite blamey language.
Yeah.
It's like you intentionally
done it
did
on
something.
purpose.
So when we say vertical transmission, that just tells it scientifically how it is.
I get that, but I was like, I feel like vertical is really scientific. Would you know what vertical
It's not
transmission
quite.
is?
It's not very obvious what it means.
I wouldn't know what it means.
But then it does take that blame away, doesn't it? Because it's like, oh, it just, things just fall vertically.
Because then it's putting the blame on the woman again. And I think it's really important that we use language that people feel comfortable with. I mean, if you're living with HIV and you decide to start a family, if you're engaged, you're on treatment, you're undetectable, you formula feed, baby's born in the safest way, the risk in the UK is only 0.14%. We haven't seen it for years. And that's a big success story.
Yeah, that's brilliant.
So it's better to know so we can put all the right care in place.
Can a baby get HIV if the dad has HIV?
So mum has to be living with HIV for vertical
Shall
transmission.
we talk
to
about how
occur.
you transmit HIV?
Yeah, I was just like, I feel like this feels like a question.
Yeah.
Yeah,
So,
it's perfect.
as we've said, the virus is in your blood.
Yeah,
So that's
unprotected
one of the
sex, so in bodily fluids, is the most common way that people get HIV. So sex without a condom, and that's different types of sex with different types of people. So that's how most people get HIV. Contaminated blood products, you don't get that in the UK now because all our blood is screened, but in some parts of the world, blood isn't screened. You might have heard about the contaminated blood products scandal, and that's from people from sort of the 70s and 80s that were given blood that had hepatitis or HIV in it. So maybe they were haemophiliac, maybe they'd had a car accident, needed a blood transfusion. So that's a very historic group of patients that were affected. So people with injecting drug use, again, that's quite low in the UK because there's needle exchange programmes, there's sterile needle provision, but in some parts of the world they see a lot more by intravenous drug use and vertically.
So because it's a virus and it's not kind of in your genes, chromosomes, that kind of thing, you're not passing it on, you're passing the virus on.
Yeah.
So it would be that you would have to have it to be able to pass it. So it couldn't go from the dad to the baby and bypass the mum.
So it's not like in the sperm cell.
So
Okay.
would it be transferred from every single this? I don't know how to explain this. So,
Go on.
if someone with HIV had sex with someone else, does the other person automatically have HIV?
No.
It's not
guaranteed.
100%. No.
So
So different
how common
types,
is it to spread?
there's different amounts of HIV in different patient groups. So that's the first thing. So it's who you're having sex with.
Okay.
Then different types of sex. So it is much easier to get HIV if you're exposed from unprotected anal sex receiving. So the risk is about 1 in 90 if that person is not on treatment, has a high viral load.
But that's if they're not on treatment.
Not on treatment.
So if you've got an undetectable viral load and you happen to have unprotected anal sex with somebody that's got HIV but they have an undetectable viral load, it's really small.
Really
it's
small
not.
chances.
This is a good time for us to just really clarify what U equals U means? Because you've mentioned undetectable.
So if you are undetectable, you're someone living with HIV, you're on treatment, and you've been on treatment for at least 6 months, and your blood test shows your virus is suppressed, so less than 200 copies in a drop of your blood, you cannot pass HIV on to sexual partners.
Okay.
You cannot.
It's a game
So
changer.
undetectable is untransmittable. It's a game changer, but it's data from 2016, and I'm still telling people today that didn't realise that U equals U.
Yeah.
It's safer to have a partner that tests, knows they're living with HIV, is on treatment, takes their medication, has their blood test, is undetectable and can't pass it on, than someone that never has an HIV test.
Yeah.
When you put it like that, it's so obvious, isn't it?
Yeah.
But it really is. Again, like you say, it's not become like a general thing that people are aware of. U equals U. Probably most people don't know what it means at all.
Undetectable, untransmittable. And just to go back to different parts of your body, sorry, I feel like we've got unfinished business there.
It's a good question.
That's
good.
It's harder to get it by vaginal sex.
Okay.
So if somebody wasn't on treatment, didn't know, and had vaginal sex with somebody else, so if you're the person with the vagina and you'd had sex without condom with somebody who's not on treatment, the risk is 1 in 1,000.
Okay.
So it's really differing.
What's the reason for the difference?
So you've got really good blood supply around your bottom.
Okay.
So that also, when we talk later about PrEP, that's why people that have vaginal sex and people that only have anal sex take it differently.
Okay.
Because the drug takes a bit longer to reach protective levels in the vagina or the front area. So we can talk about that again in a bit.
It's more likely that if you have anal sex, if there's any kind of like micro trauma to like your rectum, then your blood will come in contact with the semen, and then you're more likely to get the virus that way. Whereas vaginal sex, even though the blood supply to the vagina is very good, it's less likely than with anal sex.
And one more random question before we move on. Can it be spread through period blood?
So what are you doing with your period blood? So you're not going to get HIV from touching period blood, from washing period stained underwear. The types of people that get it from blood are people that either have massive wounds or are transfused in another sort of poorer health resource care setting with blood that's contaminated with HIV. So if you're exposed to blood that somebody is not on treatment, has untreated HIV, do you have a massive open wound, or do you have a sort of tiny graze? I mean,
can I ask a quick
your skin
question?
is a good barrier.
Okay.
Just with you, because we mentioned U equals U, and you said that essentially your undetectable viral load means you're not going to transmit it sexually.
Sexually, yeah.
But it doesn't apply to blood?
So it doesn't apply vertically. The studies were a study called Partner Study, and what they did is they took groups of people, one of whom was living with HIV on treatment and undetectable, and they had an HIV negative partner, and they were known not to use condoms. They weren't asked to stop, they were known not to use condoms. And the Swiss have known for many years and have said to people, you don't need to use condoms if you're undetectable, long-term relationship. So in that study, I love quoting this, 58,000 sex acts, that was mostly heterosexual couples, there was no transmission between the person living with treated HIV who was undetectable and their negative partner. The only people that got HIV were having partners outside of that relationship.
There you go.
So that was a lot of heterosexual data. So then we did the Partner 2 study, which looked at same-sex relationships and men who have sex with men. And they think they managed 78,000 sex acts, and again showed the same thing.
Brilliant.
That U equals U. Great. So that's where that comes from, and that's why it relates only to sex.
Yes, okay.
Yeah.
I like that U equals U.
It's
I've not
great,
heard it, but I knew that the risks were very low, but also I had not heard it put U equals U. I like it.
I have, but it's because I did an infectious diseases job in my F2, so I was like, and I did an audit on HIV and pregnancy. So I felt like I knew quite a lot. Then I didn't realise actually that the reason I know that is from that job. I kind of assumed that.
I hadn't heard of it.
But yes, anyway, carry on.
And it's ridiculous, isn't it, with the stigma there that people can't but this patient's HIV positive, and I'm like, I know they're HIV positive and their viral load is like undetectable, and they're having an operation just like other people will be. So we'll just treat them like other people. And it's I feel like shaking someone's hand or like I just. When we're saying that if you're
with HIV,
you
can kiss them, you can
you can have sex with them.
You can have sex with them, and I think there's
maybe
just
not professionally.
there's so much stigma, and that's one of the hardest parts of doing this specialty is addressing that stigma.
I think it comes from people not knowing about it as well.
Definitely.
Or not thinking they're at risk. So there is a patient I remember really vividly, you know, when a patient's story really stays with you. And she was an older white woman from the UK. She was a grandmother, and she was diagnosed really, really late. Her immune system was very weakened. She had terrible problems breathing. She'd seen heart specialists, lung specialists. She'd had scans. They were going to biopsy her lung. They told her she'd asthma. She'd had antibiotics. She'd had steroids. She'd been given all these different diagnoses. And because she was an older woman, no one had tested her for HIV. And she said to me, you know, people look at me, they see a grandmother knitting, WI, they didn't think I could be at risk, and no one did this test. And I've never forgotten that.
It's awful, isn't it? They've assumed something about her. But that's based on misinformation. So it's based on thinking that HIV only affects men who have sex with men, which isn't true. And then that has had a detrimental effect on her life because someone assumed something about her, which is terrible. Yeah.
Sad. So you mentioned condoms. What are the other prevention things?
Oh, so can I just briefly land on condoms for a second?
Yeah.
So there's lots of different...
land
land on condoms. Oh, there you go. I've given you your soundbite now. So there are lots of different types of condoms. There are femidoms, which aren't very popular in the UK, and these are large female condoms that people put inside themselves before sex takes place. They are a bit sort of baggier and bigger, and lots of people don't like them. They're a bit more popular in Europe. So male condoms are what we tend to use most in the UK. And they reduce the risk of getting HIV if you use them perfectly and consistently by about 85%. We all know that condoms can break, condoms can roll up, condoms can get left inside the vagina. You know, we all remember those jobs in A&E where you had to go and hunt the condom. So condoms are part of HIV prevention. So another really important part is testing. So testing regularly. Testing if you've had a new partner, testing if you've had sex without condoms, testing if the person you're having sex with has never had a test. So testing frequently and when there's a reason to is really important. So the other ways of preventing HIV are things you can do after you might have been exposed and things you can do before you might be exposed.
We can go into that now.
Yeah,
I think
yeah.
it's leading in nicely.
Let's do this.
So Pepsi.
Pepsi.
Pepsi Max.
We've said that these GUM doctors love their acronyms.
I feel like that's trying to get sponsorship.
So
this is post-exposure prophylaxis.
So F.
Yeah.
And the
No I.
So PEPSE, post-exposure prophylaxis after sexual exposure. So there's been sex, you could have been exposed to the HIV virus, and it's a 28-day course of HIV medication, tablets that we give people to reduce the risk of getting infected if you could have been exposed to the virus. You've only got 72 hours to access it, and it's most effective if you take it in the first 24 hours. So if it's during the day, walk into one of our gum clinics, we will see you that day. If it's at nights or weekends, you walk into A&E, and most of them are very experienced, but if they don't know what to do, they'll call one of us that's on call 24/7 to get advice about whether that person needs Pepsi or not. So that is a post-exposure prophylaxis
And
after
that's
sex.
tablets.
That's tablets, yeah. So it's 3 tablets a day for 28 days.
And how, just for people listening, so if you don't know for definite, but you think you might have been exposed to HIV, but say you have, how effective is Pepsi if you started it within 24 hours?
So we can't give you an exact statistic because it depends on who you've had sex with, the type of sex that you had, whether there was any injury, whether there was any blood. So, for example, if someone has been assaulted by multiple people, their risk is different to somebody that's had consensual sex with no injury with one person.
Right.
So we there's some guidance on the type of sex you've had, who it's with, whether there's any other factors for us to decide whether or not PEP is right for you. So come, get advice, let us give you, yes, you need it or no, you don't. And there's other things that we would do. We'd arrange screening for sexually transmitted infections. We'll give you a vaccine for hepatitis B. If there's been assault, we'll provide support. Or if there's been a pregnancy risk, we'll talk about emergency contraception. So it's a whole package of care. So if you think that there's been a risk, come and see us.
Is there any risk of taking that if it turns out that you weren't exposed and wouldn't have contracted HIV?
Yeah, good question.
Okay, so yeah, good question. So all drugs have side effects.
Yeah.
So some drugs can make you feel slightly nauseous, headachy. Some drugs can affect your muscles. These drugs are generally quite well tolerated. I'm old enough to remember giving the drugs we did 10 years ago, and they were horrible. I'd sign people off work because they had such bad side effects. But the drugs today tend to be quite well tolerated.
Good.
Yeah.
And you said that these were after a sexual kind of encounter. What about if you're a health worker, or if it's like a needle stick or that kind of thing? Because people talk about PEP in that kind of group of people as well.
So that's an occupational health. So if you're a healthcare worker that might have been affected by a needle stick, again, you get advice from occupational health, who might ring us for advice. HIV doesn't live very long outside the body. So if somebody got a needle stick and apart from an abandoned needle, which isn't that common, it's very unlikely there'd be any HIV alive left on the needle. So we wouldn't recommend PEP for that. If you've got a needle stick from somebody who's undetectable on treatment,
you don't need it.
Again, you don't need it.
Yeah.
But if you've got a needle stick from someone who's newly diagnosed, if it's a deep injury, if it's a needle that's been somewhere deep inside their body, so it really depends on the circumstances.
Yeah.
But again, occupational health or us, we will see, counsel you and give you what you need.
So that is post-exposure.
That's post-exposure
How about
prophylaxis.
the other side? So pre-exposure prophylaxis.
Prep.
Excellent.
That's a good name.
Yeah.
Yeah.
It makes sense.
And it makes sense, like
Preparation.
Yeah.
Brilliant. So pre-exposure prophylaxis is a type of medication that reduces your risk of getting HIV by over 99% if you take it correctly.
Okay.
There's different forms of PrEP. So in some parts of the world, they're using a vaginal ring. That's not that protective. It's about 53% protective. But that's in a situation where it's not easy for people to take tablets or get injections. In the UK, when we're talking about PrEP, we're mostly talking about medication. So it's a tablet that's got 2 medicines in it. So it's got tenofovir in it and emtricitabine, and we just call it PrEP. And there are also injectable PrEP now available, only in the last few months, for people that can't tolerate tablets. So it's not for everybody at the moment, but it's for people that don't get on with the tablets. So I'd like to concentrate on the tablets, if I may. Jen.
Yeah, of course.
So it's over 99% effective if you take it correctly, and it can be used by anybody who thinks they're at risk of getting HIV. So how do you take it? Depends on what type of sex you have and which parts of your body you use it. So should we focus on people with a vagina, or people that might refer to that as the front? So anybody seeking women's services that wants PrEP. So the way that you take it is, if you have sex every couple of weeks, you might take what we call event-based, where you take 2 tablets 2 to 24 hours before sex. So you have to sort of know it's on the cards. And then you take the tablets.
A lot of planning.
It is planning. So if you take the tablets once a day for 7 days afterwards.
Okay.
So that's event-based PrEP for people that are having frontal or vaginal sex. You know, if you've got time to shave your legs, you've got time to take a tablet.
Yeah,
So
I can see why you say if people take it correctly.
So we call that 2-7, 2 tablets before and 7 days of one a day afterwards. Now, if you're someone that's having, regular sex, you're having sex, once a week, then you just take it daily to be protected. And that is different for women having vaginal sex compared to other types of patients that might be having anal sex only. They can take it in a different way. But let's focus on
Would you take Pepsi if you didn't do the 2 to 24 hours before, if you just had spontaneous sex?
So it depends. It depends on how long ago the sex was, when you've taken PrEP before, the type of sex. So again, come in and see us and we'll talk to you. There's lots of things changing around PrEP that we're probably going to be using PEP less because PrEP is so protective. And so even if people miss tablets, the way we manage that is changing because we've now got more data that PrEP is, better than we thought. So if you miss tablets of your PrEP, come in and see us.
Yeah. And for us naive people that are busy working and not planning when we're going to have sex at various different times with different people, who, what with regarding to PrEP, you were saying if you think you're at risk, then you should be on PrEP. Who is at risk?
So we're trying to move away from sort of risk-based language, because
Okay.
some people don't identify with that.
Yeah.
And there's sometimes some stigma attached to that.
Yeah.
So I would say PrEP is for anyone that's HIV negative that wants to take steps to protect their sexual well-being. Now, yes, there are certain groups of people where you think that's a bit more relevant.
Yeah.
So if you've had multiple partners, if you've started a new relationship with somebody who can't or won't test, if you're seeing somebody from a part of the world where there's less access to testing or to care, if you've had another sexually transmitted infection in the last couple of months, if you've had gonorrhea or syphilis, then we would talk about PrEP with women. People who participate in transactional sex, so if people are having sex in return for money or accommodation or drugs or food, then that's another thing that we can do to help protect them. But it's for anybody who wants to prevent themselves from getting HIV. And like contraception, for people that don't want to get pregnant, PrEP means that you don't need to rely on the partner. So with a condom, you've both got to be on the same page that you're going to use it, and they've got to be happy with that, and they've got to use it and use it properly and not remove it. But with PrEP, it gives you the power to say, I'm taking a step to protect myself from HIV. Like if you take contraception, you're empowering yourself to say, I'm making a choice that I want to avoid pregnancy at the moment. So I think empowerment is so important, because it's in your hands. And sometimes in relationships, people feel that they can't talk about condoms, or they know their partner doesn't like using them, or they might get angry if you ask them if they've tested. You know, sometimes there's power imbalance, sometimes culturally, you know, it's not discussed. So I think it's really, really important that people know that they can access this and make that choice themselves.
So a key message really has been that we shouldn't assume who may or may not have HIV or be living with HIV.
Or be needing PrEP.
But someone listening might be thinking, okay, well, maybe I need to think about PrEP now. How would they go about accessing it? Or, you know, how would they go about having a discussion about whether or not it would be useful for them?
So I think the best place to do that is the GUM clinic.
Okay.
So come in and talk to us. We're non-judgmental, we're inclusive, we're confidential. We can have a long discussion with you about whether it's right for you. And sometimes it might be right for you at one point in your life, and at other points in your life you might not need it. So it isn't something you're either on or you're off. There might just be periods of time when you take PrEP. And I think, so, you know, you can't say what your partner is doing. You don't know if they might have other partners and whether they're using condoms for those other partners. So again, it puts that choice with you.
Yeah.
So I would say GUM Clinic is definitely the place that I would recommend. It's free, it's confidential, and we monitor you and we tell you how to take it.
Yeah.
You can buy it online. Again, when we're talking about dodgy websites. So I recommend I Want PrEP Now. Because they check that the supply is legitimate. Unfortunately, you know, there are always people selling things on the internet that aren't what they say they are. So I'd really recommend that you stick to either coming to get it from the NHS where it's free, or you buy
Especially
it if you're
with
buying it
medication.
privately. So there is also a big project going on. So the Elton Johns Foundation has provided some grant money for us here in Liverpool and in West Sussex and East Sussex to try and think about people accessing women's services getting PrEP who wouldn't come to a GUM clinic. So we are working with primary care and women's health hubs at 2 clinics in Liverpool. So the Brownlow Clinic on Thursday, the Women's Health Hub, and the North Liverpool Women's Health Hub. So that is a place where people might come for contraception, smears, and then we are talking to those people about PrEP to see if there's unmet need there from people who traditionally wouldn't come to a sexual health clinic. So we're hoping the idea in our specialty is that we make it more accessible through primary care, through pharmacies, through lockers, through online apps. So the idea is trying to get it more out into the community.
Yeah, that's great.
Should people be worried about taking PrEP if they want to get pregnant, if they're on gender affirming hormones, if they're on medications for other things? Is there interactions? Is it pretty low risk for being interactive with other medications?
So great question. There's a free website called the HIV Drug Interactions website. So we check the PrEP on there with any medications that they're taking. It doesn't interact with very much at all. It's safe in pregnancy. It doesn't affect your fertility. and it's safe if you're chest or breastfeeding, and it is safe with gender-affirming hormones. So the drug PrEP has actually been licensed since 2004, so we've been using it for 20 years. It's used to also as part of HIV treatment. It's not enough by itself, and it's also been used in hepatitis treatment. So we have loads of safety data.
Yeah. So there's
it
three
is safe.
websites that I think we should link at the end. The Axess website, I Want PrEP Now, and HIV Interactions Medicines, was it? We'll put a link to those at the end if anyone's listening and wants to have a quick look.
So the iBase do the best patient information leaflets, so I'm going to...
We'll link that as well.
Gate crash with that.
Yes.
And is it safe to take long term as well?
Yeah, so good question. So there is a bigger risk to your health if you get HIV than if you take PrEP. Now, PrEP is broken down by your kidneys, so when you come to clinic, so if you choose to access it in that way, we check your kidneys. Depending on your age, you might check them once a year or twice a year. And if you're over 50, you're more likely to have kidney problems anyway. And if you're somebody that we think your kidney function isn't as good, then there's an alternative we can give you, which is safe with your kidneys. So we monitor. PrEP can also affect your bone mineral density, so how strong your bones are. Unfortunately, once you're late 20s, early 30s, everybody's bone mineral density starts to decrease over time. So again, for our older patients, we do a risk score once you're over 50. And if we find out that you do have lower, sort of thinner bones compared to other people your age and gender, then there's an alternative tablet we can use in those patients.
So, when preparing the podcast, we discussed patient-first language, which is obviously really important when discussing HIV. Could you tell us a little bit more about what it is and how it is involved and important in tackling stigma?
Thank you. A beautifully planted question.
Yeah.
So, language is really important. If people have a bad experience, they're not going to come back, they're not going to engage with care, and they're not going to have such good outcomes. So the way we talk to people is really important. There's this document called the Patient First Charter, and it's all about putting the person first rather than something about them. So instead of saying this diabetic person, you say this person living with diabetes. Having diabetes isn't all that person is about. It's just a trait of theirs. So I think we're really keen in this specialty to put the patient first. So you will notice I say person living with HIV. I don't say this HIV positive person. And I think that's really, really important. So for example, I'm not a late person. I'm a person living with time optimism.
Where are you going with this?
Time optimism.
Patient first language, I think, is really, really important.
I like it.
When people say to me, "Oh, I think they were dirty," or "I'm sure they were clean," no, they were either tested or untested.
Yes.
So I think that's really, really important. So, for example, we don't tend to say AIDS anymore, which we tend to say advanced HIV because of all the stigma that surrounded sort of the AIDS epidemic in the 80s.
Okay.
So that's why patient-first language is really important. And when we talk to, we have patient representation in everything that we do and design. Some of the language that they're not keen on is risk, because either people don't see themselves as that, or it's quite a labelly thing that, oh, you're at risk, you need this. It's for anybody who thinks they could get HIV. So we're trying to move away from sort of blamey language. And, everything we do is in collaboration with communities.
I also think risk is very difficult to understand because my risk is probably my level of risk and what I think is risky is probably very different to everybody else in different circumstances. So saying that somebody's at risk or not at risk or that is risky behaviour is different, I think, for everybody.
Some people are more risk
It's very
takers.
It's not helpful, is it?
It also brings in stigma more, doesn't it? Because you're saying that essentially someone is a risky person by their risky behaviour, but then that's not a nice way to describe someone. But it also takes away...
that risky behaviour?
But then it takes away the message that anybody can be affected by HIV and could benefit from having medication to prevent that exposure. So, I can see why. It's very relevant to the specialty.
So we are very keen on that. So whenever we sort of launch any new campaigns or leaflets, talking to our peer support workers, talking to patient groups, doing some work with BHA Equality and the Terence Higgins Trust, is to make sure that we are using language that includes everybody, that doesn't exclude anyone. And I think the other really important thing is for healthcare staff, there is some... you're going to groan, some e-learning for health about HIV confidence and HIV awareness. Yeah. So trying to tackle stigma within the healthcare sector, because sadly our surveys show again and again that lots of people living with HIV have a negative experience, and it means that they might avoid or put off going to see somebody about something. Yeah. I mean, some of our patients, they have higher rates of domestic violence, they have higher rates of mental health issues, they might make different choices about having a family. There's so many areas of their life where they're going to face discrimination, and if you add in healthcare discrimination, all that intersectional, you know, you're not just a person living with HIV, you're a person living with maybe racism, sexism, healthcare stigma. Yeah. You know, it's a lot. Yeah. It's a lot. Yeah. And there were 9 people accessing women's services in Liverpool last year that were diagnosed with HIV. So what can I do differently to stop that happening in 2026? Yeah.
Good point.
No, definitely. So I guess, like, obviously beyond the medical side, there's the big piece about empowerment and tackling the stigma. Are the main things that you do, you and your staff, sort of like with language, or is there anything else you do to sort of help people when they come in feel supported and not feel judged?
Yeah, so we try to be really inclusive, so visible flags for different genders, sexualities, welcome people from all over the world. We try and use inclusive language, so everyone gets an X number. It's not an F number and an M number. Right. It's an X number, so however people identify in their gender. We talk about what pronouns people want to use, and that there are men who have sex with men who do not identify as gay. So it's really important you ask people, how do you identify? And some people don't know what I mean by that. So I say, you know, I'm Saz, I identify as a woman and I use she and her. What about you? Yeah. So making sure that we make everyone feel really comfortable. Yeah. We talk them through what we're going to do and why we're going to ask certain questions, and that we ask them to everybody. Yeah. So we try and make it really sort of inclusive in that way. I think that doing things like our social media, our Instagram, I think Facebook's a bit old lady now for me, isn't it? So all the sort of work we do with our comms teams to try and make things more accessible. There's a brilliant piece of work by my friend Lisa, one of our advanced clinical practitioners, developing an app for young people, and them telling us what they like and what they don't like is really helpful, because then we design a service that works for them. I think is really important.
In a way that they're going to give feedback on as well, rather than a piece of paper.
Exactly. Nobody wants a paper leaflet anymore. So text links, you know, short videos, you know, audios, podcasts like this. This is where people get their information now. You know, handing out a leaflet is really, really old school.
It is. I still love leaflets.
We still hand them out, don't we? Anyway, but
you got highlights and post-its. I like little business cards.
You are a little Lou, well.
And all of this is about tackling stigma, because if we're going to get to zero HIV stigma, we need to make sure that sexual health isn't stigmatised, that people aren't be embarrassed to walk into a gum clinic, and we make your sort of experience with us as comfortable as possible.
Yeah.
So when you look ahead, what worries you about the future of HIV? So we've said that they've got these things to pop in place, but I would imagine that you've got to think about some of the Trump situation that's gone on. And we have had this discussion about terminations, because we've obviously got concerns from that side, but there has been a lot of chat about HIV. So I thought we can't really just forget about it.
So I don't know if I'm allowed to reference things like The Handmaid's Tale, but
I've referenced Handmaid's Tale before.
It's terrifying what is happening for health, especially for people accessing women's services around the world. So for people that may not know, a lot of global HIV care was funded by the US, 75% of it was in fact. And when that global funding got cut without warning, that obviously interrupted a lot of programmes that prevented HIV and treated HIV. So there is an increase in infections across those parts of the world that affected. There is going to be an increase in the number of people dying. And it does affect women and children disproportionately, because it always does. So a lot of the World Health Organization and the World AIDS Day is around resilience, recuperating, trying to get funding from other sources, trying to be self-reliant and trying to not lose all those gains we've made over the last few decades, is trying to recoup and limit the harm and move forward. That being said, I'd like to focus a little bit on the UK because it is a success story that we don't talk enough about.
Okay.
So there are these aims called 90, 90, 90. Now, have you guys ever heard of that?
I think I have heard of this.
No.
Excellent.
90,
Excellent.
90. I couldn't tell you what it means.
So you want 90% of people that have HIV to know it.
Okay.
90% of people that know they have HIV to be on treatment, and of those, 90% of people to be virally suppressed, so to be undetectable.
Right.
Okay.
So where do you think the UK is with those goals?
Ooh.
80, 80, 80.
80, 80, 80? Yeah.
80, 90.
I think we'll be doing good. I think it's going to be close to
90.
like 90s, but I think the last one might be a little bit lower.
Do you think? Oh.
What's your guess?
I'm going to have to be the pessimist because you guys have all went high. So I'll go 70, 80, 90.
Okay.
79.
Okay, all right. So 95% of people in the UK know that they have HIV.
Amazing.
Well done,
With
you
HIV.
Yeah.
99% of them are on treatment.
Oh my God.
Wow.
And of those, 98% people are undetectable
Oh,
and
I'm
can't
so glad
pass
I
it
went
on.
Amazing.
Oh, that's
And
brilliant.
the UK smashed those targets a few years ago. So I spent a lot of my time with those few percent of people that don't know or aren't on treatment or not undetectable. But it's a huge success
Yeah,
story.
really.
Sorry to underestimate.
I know, I'm like, I'm
No,
not
that's fine. You can
So that must
underestimate
give
us.
you a lot of hope for the future in the care,
I mean,
HIV medicine in the UK.
It's a massive success story. If you think sort of in the 80s there was no treatment, in 1996 there was treatment, but it was 30 tablets a day.
30.
Yeah, and it wasn't until 2008 we had one single tablet. Most of my patients take one tablet once a day, and we now have injectable treatment that's every 8 weeks for some patients. And there is a 6-monthly injection coming, but you know it'll be about the money. So I
I feel like you'd be full after 30 tablets.
HIV care is a massive success story in the UK, and it's probably something we don't talk about enough. But we need to put our focus on things that we can prevent as well. So for those 9 people that were diagnosed in 2024 that were accessing women's services, you know, PrEP, condoms, testing, support, getting people in and getting them engaged with care, because nationally that 130,000 cis women that are thought to have an unmet need when it comes to PrEP. That's where my focus is on the next decade. And I think, you know, empowering choice, well-being, making sure that everyone knows, giving that information, and working and building those trust relationships, because if you don't have those relationships in the community, you're not going to succeed.
Yeah.
So that is really, really important. And I would really love to give a bit of a shout out to the empowerment campaign.
Yeah,
That's all right.
absolutely.
Do you allow shout outs?
Yeah.
You can shout out as many times as you like.
So the amazing Dr. David Rook, which is a fantastic
we know
doctor.
David
I think you know
Rook.
David.
I was just like, we agree.
He is
Great
fantastic.
piece of work in the empowerment campaign. So we think Liverpool was the first sexual health clinic in the country to actively try and speak to people accessing women's services about PrEP.
Yeah,
So it was called Empowerment, with her in the middle.
Very good.
Fantastic. As a result of that really important work, you know, the last time I checked, I think we had over 110 people accessing women's services using PrEP. So still a lot to do, but a lot better than we were, because there are some services where they have nobody taking PrEP that identifies as a woman. So I think he did a brilliant piece of work there, and hopefully, you know, if you go to our Axess website, you can read a little bit more about that campaign. And it's about speaking to people that might not think that PrEP is for them. And it's really interesting because lots of other types of patients notice the posters, notice the QR codes. So I have some patients that are men who have sex with men, and they go, can women really have PrEP? You know? And that's how the consultation starts. I'm like, yes, tell your friends. So
Spread the word.
the word.
We thought it was exclusive. What do you mean anyone can have it?
It's really important that communities know about that as well. So PrEP is an option for anyone who's HIV negative, who wants control and peace of mind over their sexual health. So that is the message.
Brilliant.
And we all love David, so that's great.
We do.
We're
He's going to
happy
be
to do
enjoying
it.
this. He better be listening to this episode.
Yeah,
I'm sure he
better
will.
be.
Yes, David.
We have got some questions for you, which are from our listeners. But is there anything else you wanted to cover that we've not covered?
I think we've talked about most things.
Okay,
Perfect.
We'll go into
We'll
our
go
little
into our questions.
Do you want to
Nice.
start?
Yeah. So someone's asked, I've recently started dating someone with HIV. how likely is it that this will affect my relationship and sex life? And I guess that depends on the partner's status.
Yeah. So I think it's a really good screening question for any new partner. You know, are you tested or untested? And I have people that come in and say, oh, my partner told me they'd had a sexual health screen. They must have done X, Y, or Z. I'm like, no, that's great.
That's good.
Yeah.
They respect you.
I'm happy about
You
this.
know that they're testing, so the chances are if they've got something, they'll have some treatment.
absolutely.
And they're showing concern for your well-being. Like, that is a great partner,
is a
someone who
green
talks
flag.
about testing. Yeah, green flag. So I think it's really important, if you don't know much about HIV and your new partner tells you they're living with HIV, that you get some more information. So often people will bring their partners or their children to my consults. So we'll sit down and we'll have a chat and we'll explain to them that if their partner's on treatment undetectable, that they can't pass it on, that they are a safe partner and they don't need to use condoms if there's no other reason for using them, like avoiding pregnancy or other STIs. So yeah, having a really open, and I would say if somebody tells you they're living with HIV, they are trusting you.
Yeah.
They are sharing a really personal bit of information, and you can't control what people do with information. And sometimes my patients tell people and they're wonderful and they're supportive. Sometimes they tell people and it doesn't go well. And you can't take that back once it's happened.
Yeah.
So if your partner's told you, that's brilliant. And they obviously think that you are special and they want to make sure they share that with you. And we are happy to help you test and to talk to you about whether you've got any other needs. So go that
It's a
person.
big green flag we love.
And on the back of that question, at what point in dating should I inform a partner about my HIV status?
Okay, so that's an excellent question. So there's legal aspects and there's, what we talk about day to day in clinic. So if you are planning to spend the rest of your life with somebody and you're living with HIV, I encourage and I try and support people with sharing that, because you get your support, you don't need to hide your medications, you're on the same page if you're planning a family, and we can answer any questions that they have. Now, that said, there are situations where it's not safe to tell people. So if you're in intimate partner violence, if there's a chance that partner might have given them HIV, but telling them could cause harm, then the most important thing is to get my patient on treatment and get them as protected as possible. So there's some situations that aren't straightforward. So legally, you've got to take steps to protect your partner. So being on treatment and being undetectable is one of those. Using condoms, your partner being on PrEP, disclosing, or if the condom breaks, talking about PEP if somebody's not on treatment. I think all of that is a bit historic now, because as we've said, so many of our patients are on treatment and undetectable, that their partners are not at risk of that. So it's different for everybody, but I certainly meet a lot of partners and we have a lot of really good conversations.
I'm really glad you brought up the legal side as well, because I think a lot of people still have big misconceptions about whether you are breaking the law if you know you have HIV and you are having sex with someone. Are you committing a crime and you are not?
No, so
which is something that is historic.
It's stigmatised in language. It's called reckless transmission if you knowingly don't take steps to protect your partner and then they acquire the virus. And unfortunately, there's been one high-profile case where someone was jailed, and that person, it was forensic behaviour. They knew what they were doing. And it was malicious. And unfortunately, that's what gets in the media and that's what stays with people.
Yeah.
So just reminding you that sort of 98% of people that are on treatment are undetectable and can't pass it on.
Which is, a huge success.
Yeah. Oh, yeah, definitely. Next question, bit of a change of tune. We love education. So this question is, should HIV education be taught in schools?
Absolutely.
That was a no-brainer.
I think you're never too young to talk about bodies, consent, what a healthy relationship looks like. I complained to my child's school that they were inviting in like pilots and policemen. So then, of course, I got invited to go in and talk. When they said, what do you do? And I sort of said sexual health and HIV, they were really worried about what I was going to talk about. But I think it's never too young to talk about feeling safe with people, not doing things that you don't want to do. There's that fantastic Pantosaurus.
Yeah.
Have you heard about this?
No.
So the NSPCC have developed this amazing cartoon with this song called Pan, Pan, Pantosaurus, what's in your pants is only for you. If someone asks to see or touch it, just say no. I'm not doing that song justice. We're going to put a link in. So things like that, age appropriate things, are so important. I don't remember anything like that when I was young. So it's really important that we are teaching young people from a young age what safe, healthy, consensual relationships look like, and empower them to call out horrible behaviour, to call out assault, to sense situations. So yeah, definitely look up that Pantosaurus video. It's a really good place to start. So age appropriate, of course. Yeah.
And does the use of condoms completely prevent HIV?
So it reduces it by about 85% if you use it consistently and effectively. That's if your partner has HIV and is not on treatment. But as we've discussed, most people are on treatment and undetectable. So them being on treatment, or you being on PrEP, or using condoms, or testing regularly, or all of the above. There's so many things you can do now.
Amazing. So we'll move on to myths. And the first one, HIV and AIDS are the exact same thing.
Okay, so that is a myth.
Okay.
So we say advanced HIV now rather than AIDS, and that is people that have been living with untreated HIV for a long time, normally years, and they've had a lot of damage to their immune system because they haven't accessed treatment or didn't know, and they are more likely to get sick, be in hospital and have a shorter life. So if you're diagnosed early with HIV, you're on treatment, we expect you to live a very long time, the same as someone without HIV. So that is a myth.
We love.
Next one, you can tell if someone has HIV just by looking at them.
Imagine.
Absolutely not. Total myth.
Imagine though someone walked in, you're like, oh my God, I can tell.
I mean, it'd be a great way for you to reduce the number of people that don't know they have HIV. If you could just look around Liverpool and be like, okay, you come to me, you come to me.
And I think that's born from the history.
Yeah.
So when there was no treatment for HIV, and I'm talking sort of 80s, people lost a lot of weight, so they could have very drawn cheekbones, they could have very skinny arms, they could get very visible signs of their immune system being weak with a type of cancer called Kaposi's sarcoma, and that had big purplish reddish plaques on their face and their body. So if anyone's ever watched Philadelphia with Tom Hanks, he loses his job because they find out he's living with HIV, and the reason they know is because he has these things called Kaposi's sarcoma in really visible areas. So it's a brilliant movie, so do watch it. So I think there became a lot of stigma that you could look at people that weren't on treatment in certain communities and think they look like they're living with HIV. So I think that's where it comes from.
But
no,
it is not true.
Just remember that British grandmother patient saying to me, no one thought I could have this and no one tested me.
Could be anybody.
Could be anybody. Yeah. So that's why everyone should have a test.
Yeah.
And I feel like this is another one that we've touched on slightly. HIV spreads really easily through sharing food and hugging.
No, absolutely not.
Complete myth.
Ideal.
That one now. And a good one to end on, HIV is no longer a problem today, it's an issue of the past.
So HIV is a very treatable condition. We've just got to get everybody that has it diagnosed, everybody that wants to prevent it, accessing things like PrEP and prevention methods, and making sure everyone stays on safe and effective treatment and it stays free. And, in the UK, we're doing well at that, but we've got to think about the rest of the world, those 20 million women and girls, about them having access to everything as well, so that we make it a thing of the past.
Get that 90, 90, 90 to 100, 100, 100.
Exactly.
Amazing. Thank you so much. I feel like it's been a great episode.
Yeah,
very much
all
so.
of the things covered.
I feel very educated.
Yeah, I think people will really like it. It was really interesting, but very relevant, and I like that we can brought it back to women's health. So it's fantastic. Thanks for coming.
Thank you for having me.
So we always do a quick disclaimer just to say that everything that we've discussed are our own opinions. They're not affiliated with where we work, and anything we've discussed shouldn't be taken as personal medical advice.
Yeah, and if you've enjoyed this episode, if you've learned something new, if you're going to start testing, please make sure you leave us a 5-star review wherever you get your podcasts.
It might seem like a little thing, but giving us a 5-star review pushes out this podcast, and it means that more people can get really good information.
And we want this episode, as well as the entire podcast, to reach as many people as possible. So if you want to be part of that ripple effect, then please hit the like button, and also just leave us a little comment. We like a review. Maybe a written review would be lovely for us to read.
It would be lovely. And make sure you're following us on all platforms at Between Two Ovaries and engage with our content.
Thank you.
Thank you.